While transfer of oxygen across the membrane of a normal lung is extremely efficient, there will always be a slight limitation in diffusion of oxygen and shunting. There is always a slight lowering of oxygen partial pressure in the arterial sample compared with that of the alveolus. The AA gradient is a measure of this difference and compares the calculated alveolar partial pressure of oxygen with that measured in an arterial sample. Certain pathological conditions can limit the degree to which oxygen diffuses across the membrane, resulting in an exaggeration of the AA gradient. Therefore, high measured AA gradients can be used to quantify the degree of pulmonary disease in some conditions. The first step in determining the AA gradient is to calculate the expected alveolar oxygen partial pressure. Atmospheric pressure at sea level is often assumed to be a constant at 760 millimeters of mercury. It is also usually assumed that the inhaled air is fully humidified, either due to the passage of air past the moist mucosal membranes of the nose, mouth and upper airways, or by artificial means in ventilated patients. At standard temperature and pressure, a partial pressure of water is 47 millimeters of mercury. The fraction of the remaining gas, that is oxygen, depends on the mixture inhaled. Room air contains 21% oxygen. Exact values for the fraction of inspired oxygen may not be known unless the patient is breathing on a closed circuit where the FiO2 can be both set and measured accurately, or the patient is on room air. Expired CO2 also takes up some alveolar space, and this is taken into account in the equation. PaCO2 must be adjusted to account for the respiratory quotient, usually assumed to be 0.8 for most patients. The AA gradient can now be calculated by subtracting arterial partial pressure of oxygen from the calculated alveolar value. When measured on room air at sea level, a gradient of greater than 15 millimeters of mercury is considered abnormal, indicating the presence of altered gas exchange. The normal AA gradient rises with age, at the rate of 1 millimeter of mercury per decade of life. The normal AA gradient is also dependent on the concentration of oxygen inspired. The normal range increases by 5 to 7 millimeters of mercury for every 10% increase in the inspired oxygen. It is clear from the above that the calculation is often exposed to biases that may cause inaccuracy. Consequently, large deviations may be significant, but smaller ones less so. A raised AA gradient implies problems in diffusion of oxygen across the alveolar membrane, i.e. the cause is intrapulmonary. This can be seen in pathologies due to flow limitation, parenchymal pathology, or large shunts. As a rule of thumb, every increase in 20 millimeters of mercury represents 1% of the cardiac output effectively being shunted past the lung. In cases of hypoxia, where there is a normal AA gradient, the hypoxia is related to alveolar dilution of oxygen content by carbon dioxide. This occurs in non-pulmonary causes due to hypoventilation. A variety of causes for this exist. Consider this case example. The following blood gas is obtained from a 25-year-old man who was intubated for a drug overdose. He was found unconscious with vomitus in his mouth. His recorded saturations are low, though his CO2 is mildly raised. Could this be the cause of his hypoxia? Remember the equation for the alveolar partial pressure of oxygen as outlined earlier. Substituting the values from the blood gas, we find he has an estimated alveolar partial pressure of oxygen of 192. The AA gradient then is the difference between this value and the PaO2 of arterial blood. When calculated, the AA gradient is 101 millimeters of mercury. It should be noted that the normal range for the AA gradient in this patient will need to be raised somewhat to account for the higher FiO2 being used, but even then the value obtained is high. This indicates that there is a problem with oxygen transfer, in this case probably due to aspiration. In this section, we've discussed the alveolar gas equation, which is used to calculate the partial pressure of oxygen in the alveolus. We've used this value to calculate the AA gradient and discuss the factors that affect its normal range. Finally, we discussed the function of the AA gradient to differentiate pulmonary from extrapulmonary causes of respiratory failure.